My name is Nazem Akoum. I am a cardiac electrophysiologist. I work at the University of Washington Medical Center, where I am associate professor of medicine and director of the atrial fibrillation program. Today, we'll be talking about a population of patients who have had strokes. It's called embolic stroke of undetermined source, or ESUS. These patients are challenging because the source of stroke is undetermined. It's suspected to be related to atrial arrhythmias. However, most of the time, there are no such arrhythmias to be detected. So we decided to dive deep into these patients and try to understand why they're having their stroke. Our hypothesis in evaluating patients with embolic stroke of undetermined source is that uh, the source of stroke is due to a diseased atrium, a fibrotic atrium, that predisposes them to form blood clots in there, independent of having an electrical problem, which is the atrial fibrillation. So the overarching hypothesis is that atrial fibrosis or atrial disease is the underlying mechanism for uh, atrial fibrillation, but also independently of stroke in these patients. The study is a prospective cohort design. We enrolled patients with embolic stroke of undetermined source from three different institutions: Klinikum Coburg in Germany, University of Utah, and University of Washington in the United States. We also enrolled some comparison control populations. The first comparison group is a healthy control. So these are patients who did not have neither stroke or atrial fibrillation. Our second comparison group was a type of stroke that's unrelated to atrial fibrillation called lacunar stroke. And our third comparison group is an atrial fibrillation group, where we tried to represent patients with atrial fibrillation and stroke and atrial fibrillation without stroke. So our first objective was to compare the degree of fibrosis in the atrium across these different groups. And specifically for the embolic stroke of undetermined source group, we followed them prospectively, and we were looking for two clinically important outcomes. The first one was new onset atrial fibrillation, and the second was a recurrence of their ischemic stroke. These two outcomes are important in managing these patients because currently the recommended treatment for patients with ESUS, or embolic stroke of undetermined source, is aspirin. However, once atrial fibrillation is detected, the recommended treatment changes to oral anticoagulation with warfarin, or the direct acting oral anticoagulants. So we follow those patients for these two clinically important endpoints prospectively for an average of 19 months with a maximum follow up of about 30 months. We had five patients in the ESUS cohort who developed atrial fibrillation during follow up. So that is about 10% of that population. We also had five patients who developed a recurrence of stroke during follow up. So that's another 10% of the population. Um, when we looked at predictors of which of these patients are going to develop one or both of these outcomes, we found that a high burden of fibrosis, and we chose a cutoff of 12% of the atrial volume. So patients with greater than 12% of the atrial wall volume affected by fibrosis were 3.3 times higher, at a higher risk of developing the endpoint of interest, so new onset atrial fibrillation or recurrent stroke, compared to the rest of the ESUS patients with fibrosis burden of less than 12%. The first conclusion was the finding that patients with an embolic stroke of undetermined source had indeed a atrial fibrosis burden that's very similar to patients with atrial fibrillation. And that was significantly higher than the control patients without stroke or atrial fibrillation or with the lacunar stroke subtype. So it looks like the disease process in these patients is similar to that of AFib, and it supports the hypothesis that atrial fibrosis is a common underlying mechanism for both the atrial arrhythmia and for stroke, independent of having the arrhythmia. The second conclusion from the study is that patients with a higher burden of fibrosis were likely to manifest with atrial fibrillation as a clinical arrhythmia. So that's important because these are patients where vigilant monitoring for atrial fibrillation can make a difference in managing them. As I mentioned earlier, switching from aspirin to oral anticoagulation can lower their stroke risk. So look very carefully for atrial fibrillation in patients with high atrial fibrosis burden. In the future, what we would like to do is enroll patients with this type of stroke, embolic stroke of undetermined source, and determine what their atrial fibrosis burden is, and do a randomized prospective study where patients will be assigned to conventional treatment, which is currently aspirin, comparing that to oral anticoagulation, just based on a high fibrosis burden, and to show that using this fibrosis-based approach to oral anticoagulation will indeed reduce their risk of recurrent stroke. So for now, look very carefully for AFib, but also stay tuned for the results of these future studies, where we're hopefully will demonstrate that this subgroup of ESUS patients with high atrial fibrosis will benefit from oral anticoagulation.